The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Blitzer. Here. Carter. Here. Asma.
Present.
Neely. Here. Glanville. Here. Coffee. Here. Conlon. Here. Barnett.
Here.
Fitzgerald.
Here.
Miller. Here. Reinhardt. Here. Vandal.
Present.
Miller. Mueller.
Here.
Van Bergen.
Here.
Roth.
Here.
Small. Here. Thompson. Here. Madam Chair, you have 18 members present. Would you do that?
Thank you. Today I'm proposing an additional committee rule regarding testimony to clarify our procedures. You each should have a copy of the proposed rule at your seat. Representative Fitzgerald moves to adopt the committee rule. Will the clerk please call the roll?
Chair Rogers.
Yes.
Representatives Whitsett. Yes. Carter. Yes. Hadsma.
Yes.
Neely. Yes. Glanville. Yes. Coffee. Yes. Conlon. Yes. Barnett.
Yes.
Fitzgerald.
Yes.
Miller. Yes. Reinhardt.
Yes.
Vanderwall.
Yes.
Miller. Mueller.
Yes.
Van Bergen.
Yes.
Roth.
Yes.
Small. Yes. Thompson. Yes. Madam Chair, you have 18 yeas, 0 nays, and 0 passed. The motion prevents.
Representative Glanville moves to approve the minutes from our meeting dated February 13, 2024. Seeing no objection, the minutes are approved. Prior to testimony and votes, if you wish to speak or express your opinion on legislation before us today, please submit a card to the clerk. Sergeants are in the room and will be happy to collect the cards and get them to the committee clerk on your behalf. In the interest of time, you are also welcome to submit written comments to be submitted to the bill record. Today, we will hear a presentation on the health challenges of diabetes and access to affordable care. We will then take testimony on House Bills 4890 and 5519. Finally, we will refer Senate Bill 249 to the House Committee on Government Operations. First, we will hear a brief presentation on diabetes, the types and causes, the prevalence in Michigan, the results of failing to manage it, and the cost to society and our healthcare system when affordable treatments are unavailable. We will also hear a personal story of what can happen if diabetes is not controlled as a result of unaffordable insulin. We also have written testimony from MDHHS and the Caswell Diabetes Institute at the University of Michigan that should be in front of you. To provide an overview of diabetes and the medical interventions it requires, we have Dr. Artie Bond, Division Head of Endocrinology and Metabolism for Henry Ford Health System, and a Clinical Associate Professor of Medicine at Wayne State University School of Medicine, joining us virtually. Welcome, Dr. Bond, and if you could please begin with your presentation whenever you are ready.
Good afternoon, everyone. Thank you, Chair Rogers, and the honorable members of the Health Policy Committee for having me here today. It's a great honor. My name is Artie Ban. I'm the member of the
Can you
Michigan
pause
State
a minute?
Medical
We're having some
Society.
Can you pause just for a second? We're having a lot of echo and feedback. Just 1 second.
Sure.
We're going to go at ease, call the chair.
Can you hear me?
We're working with our tech person. Just a second. Go ahead and just do a test, 1, 2, 3 for us. Dr. Bond, can you just, now you're muted.
Okay. Can you hear me now?
It's better.
Okay.
Let's try it,
All
let's try it.
All right. Let me see if I can increase the volume on my end a little bit more. Is that better?
Yes.
Okay, good. So thank you again for having me here today. I wanted to thank the Chair Rogers and honorable members of the House Health Policy Committee for having me here. It's an honor to represent the state of Michigan, the physicians here. My name is Artie Ban. I'm a member of the Michigan State Medical Society and the Chief of Endocrinology at a local health Michigan system. I'm a clinician scientist by background, and I'm involved in taking care of patients with diabetes. In addition, I'm involved in research studies involving type 1 and type 2 diabetes. I have served on the board of the Michigan chapter for the American Diabetes Association, and I'm involved in advocacy for our patients with diabetes. I stand here today deeply concerned about the burden of diabetes in our state of Michigan. I wanted to share a patient story from my clinic with you today. So I have a patient I'm going to call Peter, who was diagnosed with diabetes, type 1 diabetes at the age of 8. He had a very supportive family, very good patient, took care of himself, had no complications, and was doing very well. Moved on to college, graduated with honors from Michigan State University, and continued to be very meticulous with his diabetes care. He got a job. Unfortunately, the job did not come with healthcare benefits. And he was managing to pay for insulin out of pocket, and his parents were helping him too. At age 26, he completely lost any health insurance that he was under with his parents, and he started rationing insulin. He could not make all the bills with rent and food, and sometimes he would choose to buy medications, and sometimes he would just choose to buy food. His parents were helpful, but they could not stretch their dollars as much as they would want to. And one day his mom, she used to call him every day in the evening to check up on him, and he didn't pick up the phone. So she assumed that he must have had a low blood sugar episode. She drove over to his apartment and she found him unresponsive. He was in a coma. So he was taken to the hospital where he was found to have diabetic ketoacidosis. This is a condition when you don't have enough insulin in the body and the blood sugars go up and the patient goes into a coma, and it's a very serious condition. So he was in the ICU for a week, and unfortunately, just before his 27th birthday, he passed away. So this really hit hard for all of us because this is a person we had seen for years and such a good, meticulous patient with his care who passed away only because he could not afford insulin. So with that kind of information as a background, I wanted to talk to you about what's happening in our country and especially in our state here. Of more than the 38 million patients who have diabetes in America, 8.4 million users, diabetes patients have insulin as their medication of choice. Diabetes places a huge burden on our healthcare system and on our economy. Having diabetes increases our risk for having serious complications like heart attacks, strokes, kidney failure, blindness, amputation. The number one cause of blindness in this country is complications related to diabetes. The number one cause of having kidney failure in this country is diabetes, which is uncontrolled. So let's look at some data from the state of Michigan. Approximately about over 900,000 people in Michigan, which is 12% of the adult population, has diabetes. It's a huge number. What is more concerning is that about 200,000 patients in the state of Michigan have diabetes and they do not even know about it. And this is the population which is going to go on to develop complications and burden the healthcare system even more. About 34% of people in Michigan have a condition called as prediabetes, which is a precursor to diabetes. And over the next 5 years, a substantial portion of this population is going to become diabetic and will require medications, including insulin. Every year, about 60,000 Michiganders develop diabetes. And not only does it have an impact on their personal realm that now they have to deal with the diagnosis of diabetes, it also imposes a significant financial burden. Those with diabetes face medical expenses 2.3 times higher than a person who does not have diabetes. That's huge. And the cost of diabetes is not only direct. So you're not only giving them the medical expense cost, it's indirect cost because there's loss of productivity. So it hits the employers of these patients as well. More than 1/3 of Medicare costs at this time are related to patients with diabetes. And insulin by itself, 20% of direct costs of diabetes are related to insulin use because it's so expensive.
Dr. Bond, I'm so sorry, but we're still having significant difficulty hearing you. And I don't know, it is, we have checked our end. I think it's on your end. So I think we're going to just, in the interest of time, have you submit written testimony. Thank you so much for joining us.
Thank you so much, though. Sorry about the technical difficulties.
That's all right. With a personal story of what can happen when insulin is unaffordable, we have Kaylee Winters-Norrie. Welcome to House Health Policy. Come on forward and just make sure you put the microphone on when you are ready. Thank you.
I would like to thank everybody here for allowing me to come and speak today. My name is Kaylee Winters-Nori. I have been a type 1 diabetic since I was 6 years old. I was diagnosed in June of 2001, and I have been reliant on insulin therapy since my diagnosis. Growing up, we didn't have a lot of money, so I relied on government assistance programs and samples from a pediatric endocrinologist in order to maintain my diabetes care. At the time, it was called the Crippled Children's Fund. And when I went to college, I was forced to enroll in Medicaid. My father didn't want to put me on his health insurance, which was a very difficult system to navigate as a first-generation college student, the first person in my family to graduate high school as well. By my junior year at Michigan State University, not only did the system become almost unmanageable for me to navigate, but I was also working 2 jobs. I was going to school full-time, and I was still having difficulty making ends meet because my medical costs were so high. Not only was the cost of insulin absolutely abhorrent, but also other medical costs that come with that, nutritious meals and other medical supplies. This led me to some pretty dark paths, including having to steal food from the grocery store just to be able to eat. This is when I went into diabetic ketoacidosis for the first time. In November of 2016, I realized that I was not going to be able to afford my insulin that month, and so I began to ration it. I soon ran out of insulin and did not get another vial in time and ended up in the hospital. Diabetic ketoacidosis is a pain that I wouldn't wish on my worst enemy. I remember having to be picked up off the emergency room floor by nurses. I couldn't transfer beds by myself because I was so weak. I was throwing up so much and I was so dehydrated that when they called a rapid response on me, they couldn't find my veins in my arms. And I was stuck in the Sparrow ICU for 4 days. The second time that I went into diabetic ketoacidosis was in April of 2018. I had just moved back to Lansing for my first job, and I had spent every dollar I had to relocate. I had $20 left in my bank account, and I remember sitting in my car at the Walgreens in Okemos crying because I wasn't sure if I was going to be able to eat or if I had to get my insulin. I spent my last $20 on my insulin, a partial prescription pickup because I couldn't afford the whole thing, and I didn't eat for 3 days until my next paycheck came through. I had very little support, and I had really nobody that I could ask to borrow money from. I also began searching online for, there are groups on Facebook and other internet forums where people who have an access of supplies or if they are in need of supplies will illegally trade medical supplies, either for just the cost of shipping or for a little extra money on the side. Because insulin is not the only cost when you have diabetes that is, again, abhorrent. I finally have a good job with good coverage, so 1 month's worth of insulin doesn't cost this for me anymore. Without it, I wouldn't.
And just for the record, can you read those numbers? Because I'm not sure everyone can see them.
Yes, of course. So these are 2 prescription slips right next to one another after I went to go pick up my insulin. And this is how much my insurance saved me for 1 month's worth per number. 1 month, my insurance saved me $649.99. In a different month, it saved me $589.29 for 1 month's worth of insulin. Without proper coverage, I wouldn't have been able to get pregnant with my daughter because during my pregnancy, my insulin needs tripled. I went through a really heavy insulin resistance period that a lot of pregnant people do. Luckily, I'm happy to report she's 6 months old now and happy and healthy. But without my coverage, I would not have been able to have my daughter. But I am one of the lucky ones. I've been diabetic for 23 years. I've been a caregiver to children with type 1 diabetes. I've been a caregiver in an ICU with patients who have gone into diabetic ketoacidosis as well. And I have to really emphasize that this is not a unique problem to just me. There are diabetic people all over the country, all over Michigan, who are struggling to make ends meet, struggling to afford their medication, and they are dying over a drug that was sold, that its patent was sold for $1 by the scientist who discovered it, because they believe that insulin belonged to the world. So please, I do urge you to begin manufacturing here in Michigan and end the unnecessary suffering of so many who are like me in the name of corporate greed. Thank you so much.
Thank you. If you could pause just a second, we'll see if members have questions. Representative Glanville.
I don't have a question. I just wanted to commend you for telling your story and yeah, sharing what you did with us. Thank you. It's brave and necessary voice, so appreciate it.
Thank you.
Thank you. Representative Carter and then Conlon.
Yes, I would like to thank you also, especially highlighting the fact that impoverished communities suffer disproportionately because they can't afford insulin. And you'll find some of the highest incidents in urban areas where people are suffering from amputations, losing their sight, and all kinds of things that could be remedied if insulin was affordable. So I also commend you.
Thank you.
Thank you. Representative Conlon and then Vanderwall.
Just to ask what you're showing, what the insurance company saved you, would that have been your out-of-pocket or would it have been higher?
That would have been my out-of-pocket.
Right, per month?
Yes.
Thank you. Minority Vice Chair Vanderwall.
Actually, that was my same question, but I do want to say thank you for being here and sharing your story. You're just one of many, many that are out there. So thank you for being willing to come here today and put yourself in front of folks. So thank you.
Moving along, next, Representative Kofia.
Yeah, just Kaylee, thank you for coming and testifying in front of this committee. And as my colleague from downstate mentioned, this is a huge issue for lower income families in urban areas, and I can speak from a rural context in northern Michigan. I grew up in a family that couldn't afford health insurance. We have many, many, many constituents across the state who are in this position, and I want to personally thank you for your courage in speaking on behalf of families like mine growing up.
Yes, thank you. We really appreciate your time. Next up, we have Representative Conlon and Minority Vice Chair Vanderwall. If you want to make your way down. I think so. And they are going to be speaking to their bills, House Bill 4890 and 5519.
Well, thank you, Madam Chair and committee, for the opportunity to testify in front of you today. Madam Chair, members of the committee, it's no secret. Insulin prices have been too high for far too long. We've all heard about the horror stories of people who can't afford their insulin, so they end up either selling personal belongings or, worse yet, try to ration it, skipping doses and causing long-term problems. Indeed, many of us know people who have used or who use insulin, as 1 in 10 Michiganders have diabetes. The demand of insulin is high, and we've been trying for years to find a workable, cost-effective solution to lowering prices. We owe it to our people to provide stability. This legislation before you today would put Michigan on the cutting edge of healthcare solutions in the nation and revolutionize the insulin market. The bill will establish the framework for the state of Michigan to contract with a generic insulin producer to build and operate a facility that is capable of manufacturing and distributing insulin pens and vials. Not only will it create high-quality jobs here in Michigan, it will lower the cost of the actual drug. The key part of this legislation is that the state of Michigan will own the drug label, making it automatically available to people on both public and private insurance, without the added cost of being involved with a pharmacy benefit manager. In fact, pharmacy benefit managers won't be allowed to restrict access to this drug at all. No markup, no rebates, no games, just affordable, quality, Michigan-made insulin for Michigan residents. We are optimistic that this plan will drive the price of insulin down south of $50 a month, with hopes of driving it down really closer to $30 eventually. It will also do it without artificial price controls, subsidies. In fact, once the facility is up and running, we are optimistic that Michigan will become an exporter of insulin, even selling the product to other states, which would mitigate the cost. I will also add this legislation is geared towards free choice. Individuals will still be able to choose the different insulin drugs. A doctor can recommend a different choice. And the pharmaceutical companies are more than welcome to compete with this new product. This bill will put Michigan on the cutting edge of health solutions in this country and the world. Thank you. I look forward to answering any questions you may have. Representative.
Good afternoon, Chair Rogers and members of the committee. Thank you for allowing me to testify to House Bill 5519, the companion bill to Representative Vanderwall's HB 4890. My legislation is very simple. In conjunction with HB 4890, it requires reporting on the new insulin production program. This yearly report presented to the governor and legislature includes the location and status of the insulin facilities, the types and amounts of insulin produced, the percentage of insulin produced that was sold to the state, amongst other data. Thank you again, members of the committee, and we are happy to answer questions that you may have.
Do committee members have questions? Representative Van Werkum and then Glanville.
Thank you, Madam Chair. Do you know if there is actually an insulin shortage in the country?
As far as we know, there is not an insulin shortage.
Are you aware that Eli Lilly provides a $35 coupon for insulin?
I am aware of that coupon. Have you checked into the details and how you can be put on that coupon or others similar to that? This is a product that will go to all people with all availability.
Thank you, Madam Chair.
Thank you. Representative Glanville.
Thank you so much. I love the concept of this. I think in terms of innovation, what it can, as you talk about what we can bring as new solutions to healthcare, it's a great concept. But what I was wondering was, I heard you say that there would be a facility or are we just contracting with one company, or would it be possible for numerous companies to set up shop and take advantage of this production?
I think I'll answer that and jump in and feel free. We strongly will encourage all people to be involved. I think, the thought process is the state will agree with one in the beginning. Other ones will have that opportunity. But ultimately, we want to make sure that all people have an opportunity for a life-saving drug. And ultimately, we need to be competitive, and we need to be able to get that out. In long term, we know that the health outcomes and what the savings will be to the state will way out perform what's happening now in long-term issues that we see.
Yeah, well, and I can support that. My father's been through a few surgeries in the last year, as well as intensive eye care due to diabetes. So, yeah, the medical costs certainly bear out. Can I follow up? Will these facilities be exclusive to insulin, or would they be able to potentially produce other drugs as well?
I think the intent of the bill is for insulin.
Yeah, I think the intent of the bill right now is insulin. I'm certainly not opposed to that, but I don't want to get way out in front of us. And I know the good representative next to me, our number one is we know that we have a huge issue right now with diabetes in this state since the pandemic, it going up almost 3%. We need to address that situation, and this is the first leg of that.
Sure. All right, thank you.
Representative Farhat.
Thank you, Madam Chair. Thank you, Vice Chair Vanderwall and Representative Conlon for bringing this forward. I'm excited by the idea of what having an insulin manufacturer here in Michigan could mean, and I think it'd bring pharmaceutical synergies to our state as well. right, other healthcare providers. My only concern is, you know, you mentioned that PBMs would not be able to get involved in the pricing per se. Can you speak to that a little bit more? Because I think a lot of times when we see in the insulin space, and I used to work behind a counter at a pharmacy way back when, right? For those that know, they know. And one thing I noticed is a lot of times that you know, there would be higher rebate insulins that were favored over others, and so it was more difficult for a lower cost insulin option to be provided. Can you speak to maybe how this bill would eliminate some obstacles with access to low-cost, high-quality insulin in our state?
Absolutely. First off, I think for all of us, we'd have to go to basically one term of college to really understand how a pharmacy benefit manager works. But the truth of the matter is that the rebates start on the front end, and of course, they work through, and the better the rebate artificially increases the price so that it hits the market. This actually will take that out of the mix. The pharmacy benefit manager can't put on that service fee or that rebate and artificially put this in. It'll come to the Michigan resident at a true rate that there would have cash out of pocket or insurance for.
That's outstanding. Thank you so much.
Thank you. Vice Chair Whitsett.
Thank you for your testimony. When I was out campaigning for this job, one of the key things that was talked about was insulin. That was huge, and people's ability to be able to even obtain the coupons, which was a difficult thing for them because they're not savvy when it comes to computers. And doctors' offices did not always have time to do that. So when someone says the $35 of a coupon or whatever that discount may be, have you seen or heard, was that behind this bill, the intent that any dollar amount that someone has to come out of pocket really is a huge hit for them to come out of pocket for, even if it's $10?
I'll jump in. You know, ultimately, we understand how the drug market works, and when we go in a prescription, we have a copay or we don't. For folks that don't have any insurance at all, we saw the young lady that testified what that would have cost. It would have been $649. In most cases, for a person, that's a week's salary, and they can't afford to do that. So they're making choices in life. Number one, I mean, they're going to sacrifice my health. I'm going to do things that I shouldn't do legally or illegally, or I'm going to ration. And the worst thing you can do is ration or shortchange your insulin. You know, ultimately, our goal is that if we can compete in this market and we do exactly what we would like to do, I think we have opportunity that we can even reduce that cost. And I don't think we should focus solely that we hope we can get it to zero. I think we want it to be at zero, and we need to continue to work with our providers and work with the state. But ultimately, it comes to this. We need to save lives. We need to make it affordable. And we need to look past some of the obstacles that we're going to try to put in place because we're afraid of what this looks weird compared to what we've done in the past. I'm excited about the opportunity. It's 4 years. I know the representative sitting next to me has the same desire. And you know what? Ultimately, we want every one of our constituents here to be in a state that can be a leader, that can prove we can take this system and truly provide the health outcomes that we want.
And I would add that the, economic benefit to the state is great too, around the fact that when you ration your insulin or when you're not getting it adequate amounts, then you end up in the hospital, and it puts stress, of course, on our healthcare system. And so the more direct that we can get this medicine to those who need it without all these obstacles and without all of these rebates and things that make it complicated, of course, the better.
Yes, because I would like to cut down on the dialysis treatment programs that are in my community. I would like to see those not keep growing. Thank you.
Thank you. Next up, we have Rep. Filler and then Miller, and then we do have 2 more people to testify, and we'll come back to questions at the end, time permitting. So Representative Filler.
Thank you, Chair. So this is sort of Michigan competing in the insulin space against pharma. Is that how you would describe it?
I wouldn't say that it's competing against pharma as much as it's offering an opportunity for our state to be a leader in a market that has been kind of put out of touch with some of the opportunities we've been able to provide. If we want to say it's in competition, certainly I guess you could look at it that way, but I believe it's an opportunity as a state to provide a life-saving drug that we're seeing under our state-run program become very expensive and a huge burden on what it's doing to cost the state for what happens if they don't take their insulin.
Follow-up. Sure. Follow-up, Chair. There's not, I don't know how to say this another way, there's not proof that this will work, as in we could do the 150 million, put it out there, start contracting, it doesn't work out, it doesn't lower prices. This is just sort of like an attempt, is that right?
No, we actually do know that it will lower the price. That, out of the 4 years, I've been working on this bill for 4 years, and I will tell you, I do know that it will lower this price. I just don't want to overshoot the front of the boat and say that we're going to have it down at $35 or $30, but I do know that we can deliver it for 50 right now.
Thank you. Representative Miller.
Thank you so much for working on this package, because we need to keep this medication within reach. It literally will save lives. That being said, it was mentioned that there's no shortage right now, but what does that look like, you know, within the time you first worked on this bill to now? Has shortages happened in the marketplace? Do they fluctuate? Can you talk a little bit about that?
And I do know that our last speaker is going to address that if you want. Go for it if you want. But
I think that if we have a speaker that's going to address it, that's probably, but I will say that there has been availability. The cost market has fluctuated slightly since the introduction of this bill, but still a dramatic cost to the normal person that has to take insulin.
Thank you for removing the barriers to this care. I appreciate it, and we need to make it more accessible. I was not aware of the next speaker speaking on this point.
it's okay.
Thank you.
Thank you. Next up on Zoom to testify in support of the bills, we have former Representative Sarah Cambensi. Welcome.
Thank you. And I just want to say thank you, Representative Underwall, Chair Rogers, and House Health for allowing me to testify. I have a connection with this. I've been living with type 1 diabetes for 35 years. I know how important it is to maintain good control of your blood sugars so you can avoid the risk of diabetic complications. I consider myself extremely lucky. I've been blessed and fortunate to have access to good health care, first through my parents, as well as through the jobs I had. So in 47 years, I do not have a lot of complications like others could have. Though my health is not perfect, I do think that if you can truly control and give access to affordable, you will not change lives. You also change the economic and financial state of the Medicare and state health plan system you have today. One event where you send a diabetic to the emergency room for a blood test out of control, ketone acidosis, coma, the list goes on, can cost upwards and over $100,000. One incident. So these bills also prevent other related illnesses and organ failures such as heart disease, dialysis, amputations, glaucoma, and diabetic retinopathy when people no longer ration their insulin. According to the American Diabetes Association, you've heard some of these statistics, roughly 13% of Michiganders have diabetes. That is type 1 and type 2, but over 10% of the population in our state.
Sarah, can you repeat that statistic one more time? We had trouble hearing you.
Roughly 13% of people in the state of Michigan have diabetes, type 1 or 2. Those we know that roughly 150,000 of them need it. The cost of insulin, and again, I'm going to show you just what one vial is, has gone from roughly $20 a bottle in 1993 up to and over $550 a vial if you do not have insulin or insurance. Some people like myself use one bottle a month. Others, like you've heard in the testimony today, use more. So if you can't afford that medication, you have to start making choices. And that's when you start rationing it, you start cutting corners, and you drive up the risk not only to yourself, but to the other people insurance pool and the overall cost of our healthcare system. I think it's very important to recognize that the discounts and the coupons cannot long-term to this. They can be taken away at any point. They can be not accepted. I think you have to look at what is a long-term. Important to note that Michigan cannot control a private healthcare plan like and what coverage you get for prescription drugs. Much of that control lies at the federal level, if anything like that is done. Bills offer the next best possible step in where the state of Michigan can take control over that. When you think about the number of people you have on Medicaid and utilizing state of Michigan health plan, how many of those people, if they didn't have access to quality insulin, would drive up your costs? How many of them are driving up your costs right now? I think it would be very interesting and eye-opening if you actually work to pull some of those numbers to see just how much this is contributing to the rising cost of the Medicaid system. Lastly, I just want to point out that in 1923, we had researchers that were awarded U.S. patents on insulin. They sold the patents to the University of Toronto for $1 because they knew that the world needed access to insulin at an affordable rate. How we got to insulin being over $550 a bottle is a discussion for another day. But I think right now, for a very cost of the people you currently serve on the state health plans who are diabetics, who need insulin, and expanding that market in Michigan and possibly to other states should be a sign that these bills are forward thinking. I think they will drive down the cost of the overall healthcare costs in the state of Michigan. And I think you're going to set an example with a state that has more of a can-do attitude than looking at our current state of diabetics and saying, my gosh, what can we do? We hope the feds fix this. So I'd just like to thank Representative Vanderwall for working on this for 4 years. I certainly worked with him on a lot of other ideas and options, mostly with trying to limit what insurance companies could charge for insulin.
Thank you
which
so much,
simply-
Sarah. We do have one more person we need to get to, so I apologize
Sure.
that we need to move along, but we really appreciate your time and your personal testimony.
Thank you.
Finally, we have Civica RX Alan Buchel on Zoom to testify about what is involved with standing up a manufacturing facility and why it would benefit Michigan. Welcome to Health Policy, and begin whenever you're ready.
Thank you, Chair Rogers. Can you hear me okay?
Yes, we can.
Great. Well, thank you, Chair Rogers and members of the Health Policy Committee. I appreciate the opportunity to be with you, and I appreciate your leadership on ensuring insulin affordability. My name is Alan Cockle. I'm a pharmacist by background, and I lead public policy for Civica, which is a nonprofit pharmaceutical company that's developing quality, affordable insulin for the 8 million Americans with diabetes who depend on this life-saving drug. Civica was founded by health systems and philanthropies to address the problem of drug shortages in hospitals, but we've subsequently expanded the mission to lowering costs for consumers at the pharmacy counter. With this goal in mind, we have several drugs on the market or in development, including insulin. Civica will manufacture the 3 insulins that account for most daily use in the United States: insulin glargine, Lispro, and Aspart, and these correspond to Lantus, Humalog, and Novolog. and we expect Civica insulins to be interchangeable with those brand name products. We will manufacture both vials and prefilled pens of insulins in our new state-of-the-art U.S. manufacturing facility. We're funding the cost of developing these insulins and bringing them to market through philanthropic contributions, including from leading diabetes organizations.
I'm sorry
and
to
through a
interrupt, but could
partnership-
you just put your camera off a second? Because you started out clear and now it's getting a little bit difficult. So just take yourself off screen and then continue. Thank you.
Sure. We're funding the cost of developing these insulins through philanthropic contributions and through a partnership with the state of California. Our goal is to ensure that quality, affordable insulin is available to anyone who needs it. We plan to set a recommended maximum price to the consumer of no more than $30 per vial of insulin and no more than $55 for a box of 5 insulin pens. These prices are significantly below the prices charged to uninsured individuals today. And our intent with this pricing strategy is both to offer low-priced insulin directly to consumers, but also to create competition in the marketplace that will lead other insulin manufacturers to lower their prices. Crucially, we also aim to eliminate the pattern of high list prices and non-transparent rebates that are common in the drug supply chain and which serve to harm consumers, especially the uninsured or anyone who has to pay out of pocket at some point in the year based on that artificial list price. We know too well the stories of people forced to ration their insulin. We've heard some today. It leads to devastating health consequences and painful trade-offs between insulin and other household expenses. These hardships affect the uninsured and the insured alike. So I'd like to speak in favor of HB 4890 and specifically Chapter 8F, which you're considering today. As I've said, Civica will make vials and pens of insulin in our new U.S. manufacturing facility. The drug substance that goes into those vials and pens, the raw insulin, if you will be manufactured under contract for Civica by a partner company located outside the United States. We would very much like to bring that part of the manufacturing process back to the U.S. And if Civica were the private sector contractor selected under Chapter 8F, we would be able to do so. We have assessed the current U.S. landscape, and there is a need for more insulin manufacturing capacity in the U.S. Such a facility in Michigan would create 150 to 200 good-paying jobs. It would be a biotech facility producing both fast-acting and long-acting insulin drug substance. And it would be designed to meet the needs of the people of Michigan and the entire nation. Such a facility would help to ensure the availability, quality, and affordability of insulin for the long term.
Alan, thank you so much. We're still having some tech issues, but we are going to get your written testimony to all committee members. And then if committee members have questions for any of the people that testified today, you can send them to the chair and we will get those to the right folks. Thank you so much for your testimony. I'm going to quickly read in cards a moment. So supporting the bills, Blue Cross Blue Shield of Michigan, Michigan State Medical Society, Michigan Manufacturers, Michigan Association of Health Plans, and opposing the bills, Pharma. Is that? And, sorry, one more. American Diabetes Association is a supporter of both bills. Finally, we will refer Senate Bill 249 to the House Committee on Government Operations. Representative Reingans moves to re-refer SB 249 to the House Committee on Government Ops. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Whitson. Yes. Carter. Yes. Asma.
Yes.
Miller. Yes. Linville.
Yes.
Pavia.
Yes.
Conlon.
Yes.
Farnell.
Yes.
Fitzgerald.
Yes.
Miller. Yes. Ryan.
Yes.
Vanderwall.
Yes.
Miller.
Yes.
Mueller.
Yes.
Van Wert.
Yes.
Rob.
Yes.
Small. Yes. Thompson. Yes. And carried 19 yeas, 0 nays, 0 passed, motion carries.
Thank you to everyone for joining us today. I expect we will work diligently on the bills we heard in testimony today. Again, if you have any suggestions or questions, please share with the chair and or the bill sponsors. If further testimony is needed, we will hear from additional individuals at a future date. There being no further business before the committee will stand adjourned.
Thank you, Rob.